Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Livanova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Livanova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the Livanova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Livanova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Here, I need a new picture. I don't look good.
That was a good picture.
Okay. Okay, hello and welcome everyone to PerfWeb 31, Day 2. This program, of course, is approved for Category 2.7 Category 1 CEU by the ABCP. So welcome to everyone. Today's program, of course, is supported by very generous advertising through Livanova and Siemens Diagnostics. We really want to thank them for their support. Without them, we couldn't put this program on. We need more, so if you're an industry person out there and would like to advertise on our program, please get in touch with us. Before I get started with the introductions, I would like to ask all of you to do me a huge favor, okay? If you're watching us on YouTube, please, Facebook, Twitter, or LinkedIn. So YouTube, Facebook, the Twitter, or LinkedIn. Please do one of the following. Like, share, follow, or comment. Also, for you YouTubers, please give us a thumbs up and subscribe to our channel. That's probably the most important thing to us right now is subscriptions to our channel. Also, would you please go to perfusioneducation.com and leave a testimonial. It would really be appreciated, and they really are meaningful to us. We appreciate it if you would do that. If you would like to be on our program as a presenter and join our robust resident faculty, which you can see on perfusioneducation.com if you go to it, but just send us an email at contact@perfusioneducation.com. Look, the thing is, if you are interested in education, you have you have appropriate bona fides, and you like to give lectures, and you know what you're talking about. You're a content expert, obviously, or even if you are a clinician, kind of like I am, kind of an in the trenches sort of person, and you have a real interesting case report or a really good anecdotal experience that you would like to share, because I put tremendous value on that, please reach out to us. We definitely are always looking to increase our faculty list. We cannot have too large a faculty list, so there's no problem to worrying about, well, they probably have all they need. We don't. We'll take as many faculty and diversification of subjects, and all we'll do is increase the number of programs that we do to accommodate that. So please give us a call. When you see this animation, I'm not skipping it. When you see this animation, that means the phone lines are open. There it is. And now we're going to go straight to getting to the introductions. So in the studio with me, who you've met before, is Brianna. She's a graduate of Rush University Perfusion School.
Hi.
And she has been a perfusionist now for about 5 years?
3.
3 years. She acts like she's been a perfusionist for 10 years. She's here with us in Houston, working down in the southeast area, and in the medical center as well. And she's done an exquisite job and has gained, I think, a lot of experience since your move from Detroit down here to Houston. So we'll be interested to see what your perspective on all of this is. Yeah. She's also maybe a little shy, but I'm going to try to drag her out of her shell today.
Yes.
But she's got gorgeous hair. I'm going to borrow some. And then next to her is Tammy. Of course, we all know Tammy, THI graduate, been a perfusionist for 20 plus years. Tremendous amount of experience with everything from standard cardiopulmonary bypass to ECMO to PEDS to VADS to high pack to pretty much anything that we would do in the perfusion world. And I think she's going to have a lot of interesting perspective on this. And then coming to us from Amsterdam again is Dr. Keshen Mettauer. Hey, Doc, how are you?
Hey, I'm good. How are you?
Good. Dropping my cup. I'm doing good. It's all falling apart over here. Great to see you. I'm glad this is a much more civilized time of day, and you're not at 2 o'clock in the morning like you were last time. But it's great.
No, it's great. 8 o'clock in the evening to be at the office.
That's well, yeah. That's probably not doing your social life with your wife very much good for dinner. Hopefully, you'll have dinner after this. You guys in Europe, though, you have dinner later, right?
Exactly.
Yeah,
not a problem at all.
So you're good, right? Yeah, exactly.
I'm good.
So, but anyway, so Dr. Mettauer, if you don't remember, is one of the founders and is the chief science officer for Microscan Medical, right? Did I say that right?
Microvision Medical.
Microvision Medical, that's right. Microvision Medical, I'm sorry. Microvision Medical, and their product views the microcirculation and does some very fancy computations along with viewing it that gives you an idea of the health of the microcirculation. And what I'm hoping Dr. Mettauer is going to be able to address today is how there can be a synchrony between the macrocirculation and the microcirculation. And what's so exciting, Doc, right now for me with this program is not only was I able to locate a thesis, and you probably know the gentleman that wrote this. I'll bring it up after a little while, but on work that was done with animals on patients going on and off cardiopulmonary bypass and the various different phases of that. And I have this on humans, and I've looked everywhere I can look, and I have not found any published information on this being done in humans. So I may be making a stretch here, and if I spoke out of turn, please correct me. But I think this may be the first time anyone gets to see the microcirculation as you transition from native circulation to cardiopulmonary bypass in real time on a real patient having real heart surgery. And what I saw was absolutely fascinating to me. So it's certainly the first time I got to see it, and I looked around, I wasn't able to find it anywhere else. So Dr. Mark Mettauer, we need to make sure we give him credit because he was able to get us consent to do this. But what's even more exciting is we had, after the procedure, a patient arrive that was very young in extremis with gross hypoxemia. He had a arterial saturation of 72 and was struggling, a 43-year-old police officer. And I got scans of him while he was in that condition, as well as when we initiated ECMO, and then one day after ECMO, and I'll be able to show you the evolution of the microcirculation in those three different environments. So that's what our plan is for today. And in the meantime, I'm going to turn everything over to you and let you give this I think, very important talk.
Well, thank you very much. I hate to disappoint you, but it has been done in humans.
Oh, it has? Okay. That's how you know it's not disappointing. In Europe or the United States?
Both, actually.
Okay.
So let me just show you. Here we go. Share screen. There we go.
Yes. Oh man, your images are better than mine.
Well, so to get to just a general overview first so that everyone is on the same page. This is the microcirculation imaging device that we used up until a few years ago, side stream dark field. And what you see is the green LEDs surrounding lenses and a camera. And it's a way to avoid reflection of the upper surface of whatever you're imaging so that the light penetrates the tissue, and only the light that deeply penetrates the tissue comes back up to the camera. And that allows us to have kind of a back illumination, and that gives you these beautiful images of the microcirculation. So what we actually see are the red blood cells. They absorb the green light, the hemoglobin absorbs the green light, and that gives a beautiful contrast against the illuminated background. So that's basically what we're seeing, and today we've got a nice USB version of it that can easily be used in operating theater or on the bedside. So that's basically where it is. Now, why the sublingual area? I think that's also an important thing to address. The sublingual area is actually supplied by the external carotid artery, and it's one of the first few branches of the external carotid, and it turns out to be quite easily. It turns to be out to correlate very, very well with what's happening in the gut. So what we see here is we have the sham group and we have the intervention group, and then we see two lines going down, and those two lines are actually the microcirculation sublingually and the microcirculation on the gut. This is done in a pig. And you see beautifully that the microcirculation of the sublingual area follows the microcirculation in the gut. Now, from animal studies, we know that the gut is the first to go and the last to return in terms of shock or sepsis or any life-threatening ailments. So we know that if the sublingual area is bad, well, it's most likely bad, at least in the gut. But if the microcirculation is good, we know for sure that it's good everywhere. So this is probably well known already, so we don't have to go into this, but I would like to point out that the total surface area of the microcirculation is about 350 square meters, which is a lot. So this is what it looks like. What are we looking at? We are looking at black dots moving through blood vessels. And what we can see here is venules, which are the big ones. We see these smaller ones, those are precapillary arterioles. And then we have the really, really tiny ones, which are the capillaries. And what we can also see very, very nicely is white blood cells moving through that microcirculation, as this is called. What is interesting about this is that actually these capillaries are very, very sensitive to changes. So whenever there's a perceived problem and blood needs to be diverted, the body starts shutting down the flow to these capillaries and diverting blood to other parts of the body. If that happens for a short period of time, there's no problem. But as time progresses, the gut cannot handle areas where there's little microcirculation, and the cells that are not being fed start becoming hypoxic and at one point start dying off, resulting in a leaky gut and therefore increasing the inflammatory response. So in 2015, a publication was done by a group in Amsterdam, by Professor Inch's group. He's a physiologist, and he coined the term hemodynamic coherence. And basically what he means by that is that in the healthy situation, the macrocirculation, so the arteries, the veins, anything that you can see with your eyes, the blood pressure we measure, the saturation we measure, the central venous pressure, all these things are macrodynamic. So these are the bigger blood vessels, which you can see with a naked eye. Now, ideally, the situation in that macro, in a macro department, in a macro part of your body, is synchronous with the micro part. So the two are coherent with each other. And what happens in, for instance, cardiopulmonary bypass is a loss of this hemodynamic coherence. So the macrocirculation starts to behave differently from the microcirculation. So this is the paper. It was published in Current Opinions of Critical Care, and we see actually now in literature, so about 3 years later, that this idea of hemodynamic coherence has really caught on, and that it's being used more and more. So if you just, in PubMed, look for hemodynamic coherence, you will see more and more papers appearing using this term. But basically the idea is that normally when you try to give fluids to a patient, you will ideally check the preload dependency, so you will do a passive leg raising, or you will give a fluid challenge. Of course, I fully realize that most of the time that is not done and fluids are just started, but let's say in the ideal case. And then you will have you will start loading your fluid until you see that there's no more fluid dependency, and then we'll say, okay, the patient is hemodynamically stable. But interestingly enough, that could lead to still capillaries being shut down from the microcirculation, being shunted by the arterioles, because there are not enough red blood cells to go around. So what we see is that as you load fluids into the system, hemodeletion occurs. So there is per volume of plasma, there are less red blood cells, and that causes parts of the microcirculation to be completely bypassed. On the other side of the spectrum, when you don't have enough fluid, hypovolemia, parts of the microcirculation are also shut down, which leads to, because there's not enough blood to go around. And the ideal fluid volume would be where the fluid and the number of red blood cells are balanced in such a way that the body thinks, okay, I can open up this microcirculation and I give all the cells the right amount of oxygen and offload the right amount of CO2. And this is what we see very nicely in this study here, where you have a group. So they studied two groups, basically a group where the microcirculation was impaired and a group where the microcirculation was not impaired. So the dark gray boxes are not impaired. And we see that if you give a fluid challenge, the non-impaired group actually doesn't do anything. And the non-impaired group, actually the microcirculation improved, and that was accompanied by a reduction in the number of clinical signs. So oxygen saturation, lactate, heart rate, SVO2, all these things improved, whereas where the microcirculation showed no improvement, these patients did not show an improvement in clinical signs. So here we see that actually an optimum fluid balance is very, very important for maintaining a good state in the patient. And this is another study that shows it from a slightly different angle. They looked at the central venous pressure in these patients, and they found that you can look at the central venous pressure as the drain in the shower or the drain in the bathtub. If the pressure in that drain is too high, the water cannot flow out of the system. So here, in this case, the central venous pressure, if it's too high, the microcirculation cannot offload its contents into the venular compartment, and thus the flow stops. And that's exactly what they found. they found if the central venous pressure is too high, the flow stops in the microcirculation or becomes very, very low. So that brings us to, how does it look? Well, this is, for instance, a patient with a high CVP, and you see here that some vessels have flow, but the majority of them have no flow at all. So the capillaries cannot offload, and the whole system just shuts down. If you then look at, for instance, a patient that has a low blood volume, you see actually that the bigger vessels, their flow is relatively preserved, but you see whole parts, these black dots here, are actually capillaries in which there is no flow. Here you see also quite a few. Here you see a capillary that has flow, but it's surrounded by complete areas of no flow. So this is actually a shunting of the capillaries in favor of the larger blood vessels, presumably to preserve central mean arterial pressure, or the pressure in the arterial compartment. Here we have another part. So this patient has been resuscitated, has been loaded up with fluids, and what we see here actually that parts of the circulation are doing pretty well here on the top right of the image, but here in the bottom left of the image you see complete shutdown of the microcirculation. So here we see that the body actually makes a choice. It makes a choice to shut down parts of the microcirculation and keep other parts open in response to a perceived problem. And here we see a patient that is adequately loaded with fluids. You see that the flow is rather high. So that is actually very interesting. We're not sure yet if this has any clinical significance, but we see that, okay, with proper clinical intervention, this microcirculation restores. You see parts, they're actually not flowing yet, and here's on the middle part, but on the whole, this patient will do much, much better than the previous ones. And this is a very interesting image. This is a properly resuscitated patient, but the flow is so high that the camera almost cannot capture it. And we're not quite sure if this has any clinical significance, like the previous patient, but I would like to show it because in cardiopulmonary bypass, you might see this image after a while when the patient comes back to the ICU. So now, to the central question. What happens to the microcirculation when you go on the cardiopulmonary bypass? So this is a study done in the Netherlands, actually. And what they found was that if you put the patients on cardiopulmonary bypass, you will see a impaired microcirculation. So here is after induction of the patient, and the black part is the part of the microcirculation that is impaired. And the white part is the part that is preserved. Interestingly enough, on cardiopulmonary bypass, T2, you will see that almost 50%, or well, actually 50% of the microcirculation is impaired. Then, after arrival on the ICU, it drops down to normal levels. And as they get the temperature back up, you will see that the preservative effect of the cooling has passed. And you will see actually that this patient is suffering from an impaired microcirculation, which is dangerously close to levels where you need to do something. So this is about 70%, which is below the cutoff of 80%, which we usually maintain. And then a few years later, we have this study from Canada. And they did something similar, but they compared off pump, which is the OP line, the blue line, and with on pump, cardiopulmonary bypass, which is the red line. And what we see here is very, very interesting. When they are on the pump, actually the microcirculation is better in the on pump group than in the off pump group. But once the first grafts are being made, so the first graft is 3, second graft is 4, third graft is 5, you see actually that the microcirculation improves, shoots up in the off pump, and continues to decrease in the on pump. And then once they're on the ICU,
I know why that
which
is.
is 6, and then 7 is 2 hours on ICU, and 8 is 24 hours on ICU, you see actually that the off-pump group has pretty much restored its microcirculation back to normal, and the on-pump group has decreased its microcirculation and has not gotten back to where it was pre-op. So here we see that the cardiopulmonary bypass actually has a very significant effect on the microcirculation of these patients. So that was on pump. Any questions or comments?
Oh,
so
we
far?
have a whole bunch, but we're going to wait until you get through all of this.
Well, I was thinking that. So
You want to go back? Okay, then let's. Okay, that's fine. Tammy, you want to go first? Because I've got several really important questions that I want to answer.
Yeah, I have 2 so far. So when you were talking about in the beginning about why you do the lingual area and it's correlates to the gut, and you were saying that a small amount of time with impaired or stopped microcirculation is okay. What is that amount of time? Are we talking about a few minutes, half an hour? What would be acceptable as not shutting down the microcirculation for just a small period of time?
Well, we know that 24 hours is definitely too long.
Okay. So it's probably some hours, not just minutes.
Yeah, not minutes, probably hours. I would say 3 hours, 4 hours, still okay.
Okay.
Any more than that, and you'll be probably in trouble.
Okay. And then my second question was about the 2008 study that was published in Thoracic CV Surgery. Why do the microcirculation after they're off pump and arrive in ICU, why does it continue to go down? If they should be already warm and at a good temperature, I was just curious why it didn't start increasing there.
Well, actually, it increased almost to normal. So if you see the white part is almost back to what it was after induction.
Oh, I see.
So it actually
okay, I was
improves
reading
a lot.
that wrong. Okay, great. All right, that's it.
But later, you
On
see
the
there
ICU.
in the ICU over time. I think that's what her question is.
Yeah, that's my question.
What caused that degradation?
Yeah, so that's a very good question. So the study does not answer that, but they postulated maybe due to vasopressors or fluids or some kind of intervention that was done on the ICU that caused that deterioration in microcirculation. So maybe it wasn't even something systematic in the patient. Maybe it was intervention by the physicians that caused this, but they don't know for sure.
Okay. All right. That's what I was wondering, if it was possibly due to drugs or fluid overload because these patients are, not having a mean arterial pressure that they want. And okay.
Yeah.
All right. Thank you.
See it all the time.
Probably.
The patient gets to the ICU and it's a fire drill, and something happens, the pressure goes down, and they immediately turn on the Livanova or whatever else they're going to do. So I mean, we see that a lot. Brianna?
I have one question. Back when we were speaking about hemodilution, you mentioned that capillary shunting can occur because of the decrease in circulating red blood cells, and I was just wondering if there was like a reference point or something where we can look out for while we're in the OR, like something to help us recognize this may be occurring, or will we just find out like after the patient leaves the OR?
Yeah, so as far as I know, there are no real parameters you can look at to figure this out.
Okay.
And I'm assuming each patient is going to be unique in the sense that one person may have a significant microcirculatory change, negative change at a hematocrit of 36, and another person might not until they reach a hematocrit of 30. I mean, I guess we just really don't know that.
Okay.
We don't know that. Yeah, exactly.
Did you have another
There's
question?
tremendous individual variation in this.
Did you have anything else?
No.
No. Can you go to that slide that showed the blood going through the microcirculation very rapidly after there was resuscitation? I think it was your last video.
Yeah, the hyperdynamic
The
one.
hyperdynamic one.
Yeah.
Yep, this one.
Yeah, that one right there.
Yeah.
So, of course, I'm just trying to, I'm trying to imagine that the patient was resuscitated, and do you ever see a hyperemic response in the microcirculation like we do when they do a coronary, for example? And they measure the coronary blood flow, and they'll occlude it, and then when they release it and it first starts flowing, you get this very high flow, but then it trails off. Is that something that you might think would be happening here?
It could. We don't know.
Okay. And then
It could.
if you go to your first slide on CPB, that one there, first slide, yes. Okay, yeah, we addressed that already, so you had the same question I had. So go to the second, CPB on pump versus off pump.
Oh, yeah.
Okay, so what I think happened there, and of course this is, how many cases is evaluated here? Was this was
Yeah,
32
so 16,
patients?
16.
16 and 16. So
Yeah.
what I'm thinking is they did their first graft, which was either a OM or a circ or something like that. They pulled the heart up, and you had a decrease in overall perfusion, but then they put the heart down to readjust it to do another graft, and that's why you see the improvement at that point in time, because we see that all the time.
Right.
That's what we think
Probably.
happened.
Yeah. Most likely, yeah.
And it's positional to
Absolutely.
the heart and affecting the perfusion. Whereas on pump, of course, you're going on and you're not manipulating the heart. You're not, because anesthesia is always giving a lot of voodoo juice and fluids and everything else to accommodate that first off pump graft, because they're pulling the heart over so much. That's what I think anyway. Okay, thanks, Doc. Next section.
Yes, so to pulse or not to pulse, that is, of course, the question.
Yes, we know. We know.
So from a microcirculation perspective, it's actually pretty clear. So this is a study done, I think also in the Netherlands, if I'm not mistaken. They looked at 33 patients, I think 16 and 15 or 16 and 17, something like that. And you looked at pulsatile and non-pulsatile. The gray boxes, the dark gray boxes, are the pulsatile, and the white boxes are the non-pulsatile. And what you see here is 3 is a good microcirculation, 0 is a bad microcirculation. 2 is, well, not too great, but you'll live. And what we see here is actually a steady decrease on non-pulsatile of the microcirculation, and a pretty much steadying or slight increase of the microcirculation on pulsatile perfusion. So from this, it's pretty clear that from a microcirculation perspective, you're better off with a pulsatile system.
Well,
And the second study.
Go ahead. I'm sorry.
Oh, that's okay. Second study done also again in Canada shows similar things. They did not have a nice graph, so I just added the pictures. But basically, they found the same thing, that the pulsatility had a much better effect on the microcirculation than non-pulsatility. And they have tables with their results, but yeah, that doesn't come across nicely on a PowerPoint. So, but pretty much the same result. So these are the two studies mainly available on pulsatile and non-pulsatile. Any questions about those?
Yes, absolutely.
Yes, I have a
You are.
question.
Go ahead.
Okay, were roller pumps used on both of these? I see that
Yeah.
it was used
No,
on the
no.
second one.
This is one is a centrifugal pump,
Okay,
and the second one is a roller pump.
okay.
Well, you have completely ruined everything that I have always believed that pulsatile perfusion on cardiopulmonary bypass with that artificially created, if you want to call it a pulse, was of absolutely no value. I never believed it had any value at all, and you know that. I mean,
And that's why I made sure to ask if it was used with a centrifugal or a roller head.
But both.
Both.
Right.
Right.
So clearly, I've learned something here today. But with that said, also, how is this going to impact on a sort of a broader perspective? How is this going to impact the total artificial heart market, which has almost entirely shifted from a pulsatile pump to a continuous flow pump?
Well, in all honesty, even though this is quite a dramatic result, we do know that if this continues longer, the body starts adapting.
Okay. So there
okay.
is a period of adaptation.
Yeah.
Okay.
Yeah. So I don't know exactly how long that is. This is more mainly animal studies. But we do see that after a few days, the body starts adapting and normal flow patterns start returning.
Very good. I have a couple of questions from our online audience. Was on the studies that you showed on the cardiac, on pump, was the cardiac index maintained throughout the procedure? In other words, what the predicted or calculated required flow would be for that patient. So in your on pump study, of course, it's going back to the previous section, but I just got to the questions. That's question one. And then also, do these studies measure the PCO2, and is there any correlation between the PCO2 having hypercapnia or hypocapnia or normal in terms of how it affects the microcirculation, since we know CO2 does certainly influence cerebral perfusion? And then last, there's some other questions, but let's go with those two first, and then I'll ask you this last question from our online audience.
Yeah, cardiac index, I haven't seen in those papers. Maybe it is there and I overlooked it, but I don't think it's reported.
That's a very good point.
That's a great point.
I think one of them has a table that shows, and I don't remember seeing much difference in cardiac index, but that was more an average over the whole thing. And the CO2, I don't remember. I have to really look into it.
Well, what is your thought on it? Do you, I mean, just intuitively, we know you can get a significant increase in cerebral blood flow by raising the PCO2 by simply 5 millimeters of mercury. It doesn't really take a whole heck of a lot. Conversely, you get a reduction if you blow it off. So intuitively, do you think that would influence what the microcirculation does, or is that really only a macrocirculation phenomenon?
Well, there are two things. So one, if parts of the microcirculation are shunted, you will get increases in CO2, but they need a longer time to diffuse back to a capillary that is working. So yeah, intuitively, I would say that the CO2, the PCO2 would increase with an impaired microcirculation, but whether it accurately reflects what's going on.
Well, no, I think you're misunderstanding my question.
Yeah.
The question isn't that. The question is, let's just take, for example, a patient that's on full cardiopulmonary bypass, and we have our sweep gas, or what would be considered our tidal volume and rate, set at 4. And we run a blood gas, and the PCO2 comes back 24. And so it's very low. And at that point, were we to check the microcirculation, even though we have great flow, would we see a difference in that patient versus taking that same patient, reducing the sweep gas down to, let's say, 2, and having a PCO2 of 45 or 50, for example, where you would then see a more open microcirculation, would you see? Do you think you would see anything in either of those scenarios? And of course, if you don't know, then that's what I'm going to do the next time I go in and do this at the hospital.
Yeah, I don't think anyone has ever looked at that.
I'm doing it. We're doing it. We're doing it Monday. We're doing it Monday. Okay. And then there was one last. One last question, and that was multiple factors here is both the pressure, hemodilution, colloid osmotic pressure. Yeah, so there's a lot of discussion. I think the question has to do with on those patients that were on pump, did they measure the mean arterial pressure, the hemodilution, the colloid oncotic pressure, COP, the index, and temperatures?
Mm-hmm. Yeah, they kept that. They tried to keep in both these studies pretty much. They tried to keep it as similar as possible in all these patients. That was the protocol.
Very good.
Yeah.
Okay.
All right. I know that for sure in this study because I know Dr. Denel personally, so we spoke about this study. So I know they did here. In the beans, I don't know for sure what they did, but I'm pretty sure they did the same because it's an obvious question. So this was pulsatile. So now the other section in the program was, okay, how to wean the patient off the cardiopulmonary bypass. Now, there are no studies investigating that, as far as I know. But we can maybe look at ECMO to see if there are any parallels in that whole process. So this is a very nice study done also in the Netherlands. And we see here that if you reduce the flow to 50%, you have basically two groups. So one group where the microcirculation is pretty much preserved, which is the left chart. And then on the right chart, we have you reduce the flow to 50% and it just collapses. And this gives you an indication of, okay, maybe this patient is not ready to be weaned off.
I would say that's really sort of predictive, and I would not think so. I don't, intuitively, if I were to see something like that, I would not be encouraged to continue.
Yeah, exactly. So that's one. So we don't know whether this also goes for cardiopulmonary bypass, but I think there probably is a similar dynamic going on. And here we have another study, which is a larger study, but in Taiwan. So, you know, we may look at it a bit more critically, but pretty much the same thing. What they did was they looked at survival in these patients with cardiogenic shock. And they looked at, okay, if the microcirculation remained good, which is the blue ones, those are the survivors, and the green ones are the non-survivors. And you see that in each case, when the in the case of the survivors, the microcirculation either restored or remained relatively well, so close to, in this case, the PPV chart 100%. And we see here that with the non-survivors, you actually see a slightly downwards curve. You can recognize it a little bit in numbers, slight downwards curve in those patients that will eventually die. Now the question is, then what do you do? And that is something still under investigation. I think the what do you do question in this case is very intensively studied at the moment. People are really wondering, like, okay, is there a way we can prevent this from happening? But at the moment, we don't have an answer to that yet. But again, I think if you have a patient that is in cardiopulmonary bypass and you shut the system off, it's good to just look at the microcirculation and get a feel for, okay, what is it doing, and should we keep this patient on a little bit longer, maybe tweak a few other things before we try to completely let this patient go to the ICU. But that is something I think for you, Joe, to to figure out in the coming months or years.
Yeah, decades. Hopefully I'll live to 100 and I'll have the time.
So those are the two studies from ECMO that are quite recent and that we know say something about weaning the patient off. And I think this study in particular was really, really eye-opening for a lot of people. So that's the weaning off part.
Should we ask a question now about this particular?
Yes, please.
Okay, I just have one quick question. When you're talking about reducing the flow to 50% to check the microcirculation to see if they're possibly ready to be weaned off ECMO, what's the recovery time once you increase the flow again if you determine that they're not ready? How much are we impairing the microcirculation?
Yeah, so within 2 minutes it dropped, and then within 3 to 4 minutes it came back again.
Okay.
And we're impairing it by, almost half. So we see a reduction, a 50% reduction in functioning vessels.
So if I can add to that question, how long, when you, let's say you reduce the flow, normally what we do is we're not quite that fast. We're going to go from 100% flow to 90% to 80%. Yep. Sometimes we'll even make it by increments of 5. So we'll go from 80 to 75%. We very rarely will go all the way just down from 100 to 50%, except under some very rare circumstances. So if you're doing this, and every change you make, would you recommend just doing, every time you make a change in flow, as you're reducing it, do an analysis at that point, and then as you see it continuing to maintain, you feel more confident to continue to come down and wean, versus if you start to see a degradation, maybe not 50%, but instead you see it drop all of a sudden 10 or 15%, and you sit there for a little while and then maybe try a little further and see it fall yet again, I think you would get the indication before getting to 50%. But I think your question, what you were trying to ask, is whether or not doing that to test the hypothesis, to see if they're ready to wean, will have a long term or more a longer duration effect on the microcirculation. Right. That's the question.
Right.
Or does it pop open fairly quickly?
Well, he said within 3 to 4 minutes they recover. So.
But how long were they down in this study? Let's say you stayed down for an hour. You tested it for an hour.
No, 2 minutes.
Yeah, this test was just 2 minutes.
So if you drop 50% in 2 minutes, it's not going to on its own get better.
No.
Okay. Fair enough. Now,
and in another group, it did get better on its own.
Oh, really?
Oh.
Okay.
Yeah. So that's the weaning. That's the left.
That's the group.
Okay.
The
ones that did right. Those that were able to be weaned successfully.
Yeah.
Okay.
So what they actually were trying to figure out is, because of course they do the weaning also gradually, like you just described. But what they were trying to figure out is, okay, are there patients that by giving them a challenge, a bit like a fluid challenge, but then a weaning challenge. If we give them a challenge, can we say, does that help us gauge or get an idea of, okay, is the system of the patient ready to work on its own? Yeah. So I think that's why they chose the 50%. You just give a challenge to the system. Does it respond as it should? So, which is the left chart. Then, okay, we'll start weaning them off, because they went back to 100 again. So 100, 50, 100. And we have patients that if we do the same challenge, 100, 50, 100, they just drop tremendously, and they return when you go back to 100 again. So I think that's what they were going for.
Yeah.
That makes sense, because they're not necessarily going from full flow to half flow.
So what they're saying is we can do with this patient, responded appropriately to this very brief duration of 50% reduction in ECMO flow. Now we feel confident in starting the
normal wean.
gradual reduction until wean. Okay, well that makes a lot of sense. Do you see any correlations? And this is a question from somebody, but I'm sort of rewording it for if he doesn't mind. But do you see any correlation in what we use as inference all the time is lactic acid? We look at lactic acid levels. But how much correlation do you see between the sublingual side stream dark field imaging and lactic acid buildup?
Yeah, so that's a good question. The lactic acid usually has a delay of 1 or 2 hours behind what we see in a microcirculation. So it correlates, but later in the process.
Very good. Yeah, that makes sense too. Well, I was having this conversation with somebody the other day in the hospital, and I said, we use a lot of information that we infer other things from all of the time. But every single one of these things has a delay, and then we only check them every so often. So you don't get an immediate, anything. And of course, with costs the way they are, nothing, not to say that, I don't even know how much that device costs. I was grateful. I'm still grateful and never be able to repay you for you letting me play with it, but it's costing zero, except for probably the cost of the disposable probes. Laboratory testing now is extremely expensive, not to mention then you have to worry about, taking blood out of your patients. How many times do we have transfusions associated through laboratory testing, So those are all serious concerns.
Well, especially on ECMO. Usually we're only doing lactate maybe once a day if we're lucky.
Right.
So it's extremely delayed, and by the time we're getting the result, it could have been normal today, but by the time you do yours tomorrow, it's not normal.
Right, then it's 7.
Right.
And everybody's wondering why this patient is crumping. Right. Yeah. Very good point.
Exactly.
Okay, did you have any more slides?
That's it.
Okay, good. Well, I'm going to throw up my slides if we can, if you guys would be so kind. And then I'm going to show you some videos, but I have only a very few slides. And so this is that doctorate thesis I was telling you about. And, I found this and started reading it. And I have not read it critically nor completely, but I've glanced through it and picked out some things that I thought were very relevant and I think are going to bolster what you just got through saying. So let's see, next slide. So this is basically what this thesis looked at, and you can look through all of them, but they address everything from changes in microcirculatory perfusion and oxygenation during on and off pump cardiac surgery. Microcirculatory perfusion is preserved during off pump but not on pump, which is what you just said. Pulsatile flow, which I think there's a reason for that. One, I'm going to tell y'all, I'm going to say this. One of the things that has always bothered me when you compare on pump to off pump, because it's just like surgeons, it's just like anesthesiologists, it's just like PhDs. It doesn't make any difference. They're not all created equal. They never really truly describe the perfusion assets that they're using, nor the technique that they use. Those are never well described in any of these studies. It's just on pump or off pump. And there's a lot of different ways that perfusionists manage the conduct of their cases. And I think that that's something that has always bothered me, that I don't think it's ever really a true representation of what I do, you do, and some other people that I know do, but is for those people over there. Do you feel the same way?
Yes, and I also think that going back to the surgeon, I wondered if those studies, were they all on versus off, was it the same surgeon? Because someone who is necessarily good at on pump may not be good at off pump, or not as good.
Sure.
And sometimes the off pumps are chosen specifically because how many bypasses you're doing, or the
And they can't tolerate the
Yeah.
off-pump technique.
right. And so a patient might be sicker, of course, who goes on pump versus who is off pump. So I'd like to know all those things too, because you really have a lot of parameters that you need to make the same.
I've always found that to be a problem with a lot of these studies, and that I don't think they describe that quite well enough for
And they
for
may
my
be
liking.
comparing like things, but you're right, they don't tell you.
But he also looked at pulsatile flow versus continuous. He looked at shunting through hyperdynamic capillaries going on. Say that again? Oh, can you see what I'm looking at?
No, I cannot.
Oh, that doesn't do you any good. Well, let's fix that. Hold on, we're going to fix that. Yeah, it's okay. There. Now, oh my God. I see myself. Oh,
That's a large joke.
That's a large Joe, yes. I want a diet though. Okay, so I went through the list, but let's just go here. And this is something, but I think chapter 9 was very interesting, and that had to do with vascular leakage. And they were using a drug, imatinib, which I guess is a kinase inhibitor, to help to correct that. And I wonder how much we see with the microvision scan, or microvision scan, right? Am I saying it right finally?
Yeah.
Microvision
Scan. How much of that you can see of capillary leakage?
Well, you can see the boundaries of the vessels become fuzzy. So you can see it with your eyes, but so far we have not found a way to objectify that with an algorithm.
Well, you're fixing to see exactly what you're talking about when I show you these videos. But anyway, so I thought this was interesting, what his central hypothesis was in his thesis. Cardiopulmonary bypass, endothelial cell activation, hemodilution, increased vascular permeability and interstitial pressure, reduced microcirculatory perfusion, and then leading to, of course, organ dysfunction. I mean, I thought it was a really good look. I have to read more of it, but these are some of the things, again, cardiopulmonary bypass on versus off pump, that he found. That, of course, on pump, the temperature goes down. That's not necessarily true, but in this case it was. But yet it's equal in off pump. However, I will tell you, many times I find patients in the off pump group colder than the patients that were in the on pump group, but that's another question. Hemodilution, yes, but we really try to use minimum prime circuits and smaller circuits and different techniques that we use, so I think we're getting a better handle on that. Cardiac output was better in the on pump versus off pump. Blood pressure was down in both. Oxygen delivery, or DO2, was down in both. Hemoglobin concentration was decreased in the on pump, but not equal in the off pump. And you can see the rest of them there. And blood viscosity, probably secondary to hemodilution, was decreased in the on pump versus the off pump group. But of course, we use albumin. We're very careful about measuring. We don't measure the COP, but we will measure an albumin. A COP would be better, but we're real hard to get that test here for some reason. We really try to keep that viscosity up because we're very sensitive to third spacing of fluid, and we want to avoid that at all costs. But I'll let you read his conclusions, and really it essentially says the same thing that you said, but he really focused a lot more on the inflammatory endothelial barrier dysfunction and also vascular leakage. And he also talked a lot about the glycocalyx in his particular study. So if you get a chance to read this, Dr. Mettauer, unless you already have, I would recommend it. It's really pretty good. Okay, so now let's go to my videos. Let's go to the fun stuff. So this first video I'm going to show you, as soon as we get it, there it is, I see it. So you want to just pull them up for me and I'll tell you which one to open? Yeah, go to the on pump. So go to the baseline, the second one. Yeah, right there. So open that one. Okay, now, before we click start this thing, keep in mind, I'm an inexperienced operator, all right? And you're probably gonna, I hope, send me an email with some ideas on how I can make my imaging better because I have struggled with it. And I will tell you that doing this on this pump case was very challenging because, of course, you have the drapes up over the patient. I'm ducking my head under there and trying to put the probe in, and anesthesia is kicking me, and the surgeon's elbow is hitting me, and they're throwing instruments down on there. Then they're yelling because they have suture on there. So with that said, I remained remarkably calm and did the best I could do. But I do think that there is a learning curve that people have to do with this to really develop the technique to be a great imager. Okay, so now I can control it now? Yeah. Okay, so I need to move this thing. Okay, so this is our pre. And I move around a little bit. I think I want to get to about 1240. Oh, no, this is a very short video. So what do you see there? What are you seeing there? It looks normal to me.
It looks pretty normal, yeah, exactly. So you see here nicely the red blood cells flowing through the microcirculation. Maybe there are a little bit less capillaries than we want to, but of course this is a sick patient, so that's not entirely unexpected. So on the whole, this does not look.
Let it get a little bit.
This looks pretty good.
Let me go back. There. This is okay. This is just before I decide. Yes, I noticed that too. That the capillary density, I guess you would call it, and the number of crossings was the other thing. Can you please discuss for us the de Baker scale?
Yeah. So the Baker scale is actually very simple. So it's derived from pathology. So what pathologists would do when, for instance, counting bacteria in a field, they would draw these lines, and they would just count whenever they saw something intersecting with those lines. And it would just be a very quick method to take a complex image and reduce it to something that you can note somewhere and give a number to. So Daniel de Bakker from Brussels University, he applied the same principle. He said, look, we have a complex image here. I need to reduce it to some number that I can use. I don't want to waste too much time analyzing it. So this was in the days before computerized analysis. He did it all by hand. So what did he have? He had some graduate students sit somewhere in a dark basement and sit behind a computer and just count every vessel crossing there and saying, okay, this vessel has flow or non-flow. And then he would go to, he would just do number of perfused vessels divided by total. And if it's 100 or above 80, it's okay. If it's below 80, then we've got a problem. So that's basically how it is. So that's a relative score, and then you have an absolute score, which is that consensus density data there on the right. Number of crossings are the actual number of vessels crossing a line.
Okay, very good. So that consensus PPV of 100 with the consensus PPV of 95, you would say is a good number.
Yeah,
those absolutely are good numbers. And a de Baker density of 8 is considered. Is that 80? Is it a number that is that a decimal, or is that number good, bad? What's the how do you
so
how do you describe
that's a good
that?
question. We don't know.
Okay.
Because the number of crossings depend heavily on the patient. So it's influenced by ethnicity, it's influenced by age, it's influenced by health status, smoker, non-smoker, runner, non-runner, stuff like that. So if you would have a marathon runner here, it would be a number of 12 or 13.
Okay, that makes a lot of sense.
An 80-year-old smoker, you would probably have a 6. So that number doesn't really tell us much.
Okay.
So it's really the relative number that tells us something.
Gotcha. So now, just very quickly before I go ahead and pull my next video up, but were you one of those grad students that was counting crossings in the dark basement? No?
Yes, I was not in the Bakker's lab, but...
Wait, go back. Take that out. You were in his lab?
I weren't in his lab. No. I was in another lab, but yes, I had a basement room with no windows.
That's horrible.
Been there.
Okay,
Yes.
can you go to the third one, the one that says pump, cross clamp? That one, yes. So let's see that one, okay. Now, here the patient is, now is this the one, I think this is the one where we're going on bypass. I'm not sure, let me see. Let me go to 1240. Let me see. I'm trying to remember which video I'm looking at here. I think this may be it. Nope, yep. Go back, go back, go back. Okay, this, I think we just did this. Okay, and then we did an analysis of this. So here again is the patient's normal circulation. We abandoned the analysis because we were going to be going on bypass, or I think we did. Maybe we didn't, so let's just wait. And forgive me for grinding through this, but we're trying to figure it out as we go. Yeah, there you go. Okay, so you see from opening the chest and taking the mammary down, you saw, oh, gosh dog it.
Yeah.
Let me go back
So
to
the
that.
small was around 85, if I'm not
Yeah,
mistaken.
there it is right there.
Yeah, 86. There we go.
86. So there's already been a change. Now we're not on bypass yet. This was still pre-pump, but they had taken the mammary down. The patient had been under anesthesia for probably about 40 minutes. They had harvested a couple of veins from the legs. There certainly has been some trauma. Of course, they've had a sternotomy, and that's going to create some kind of process in and of itself. Now we'll go ahead and put the patient on pump. And I'll move a little forward. And it was, for me, it was frightening to watch, actually. Let me see if, let me come back a little bit. Let me not go so fast forward. 850, is it? 6, 7. Let me go, I'm getting up there. All right. There we go. Now I think this is where we go on pump. And watch what happens. Wait for it. And I think that's it. We're on pump. Okay. So let me go to, let me see, what did we do with this, Magic? Do you remember? I don't think that was the one. Let me go back. It was awfully remarkable. So hold on. I think I was at the wrong place. 1354, 1312. Yeah, this is it right here. Here it is. This is the one going on pump. So I've gotten a spot. This is the one going on pump. Forgive me. Because the change is so remarkable, it's frightening. Give it about another 30 seconds. But do you, it seems to me that there's a lot of, of course, the reflectivity. Are we seeing a white cell invasion here, or is that just some kind of, and when you see these various capillaries with flow, now look at it going away. Look at it. Yeah. That's when we went on pump right there.
It's quite dramatic, yeah.
That is amazing. And then I let it run for a little while, and I was having a hard time holding this camera steady. You can see I'm a little out of focus, but every once in a while it comes back. But you can see now we're up to full flow. And you kind of see some of the smaller vessels starting to reemerge, but it certainly is not what it was by any stretch.
No.
Not by any stretch. We've lost a lot here. And I think we did an analysis. I'm going to go ahead for the sake of time and move forward and get to the analysis. There it is right there. So interestingly enough, look, 96%.
Yeah.
Now the Baker score went down, but yet this
Yeah.
was there. But yet my eyes tell me that there weren't as many red blood cells present in those vessels.
Yeah.
And I think
So there you see a bit of the weakness of the system. And I think we need to give you a different version of the software, because the vessels that were detected had flow.
Yes, understood, exactly. Okay, let's go to another one. Let's go to the one that says, let's go ahead to the pulse flow.
Yeah. So what we would do here is actually, so that number is not in this version of the software, is that you look at the length of the vessels, and then you will see a decrease, and then you can normalize that
Yes.
PPV against the total number, and then you.
So you're telling me that Zahid cheated me? He gypped me on my free device? Zahid the cheaper.
Yeah.
I can't even say it. Jipper.
Jipper.
That's it, Jipper. Okay, so here we are. Let's see. I need to go to 850. 850. 749. Okay, here we go. That
looks pretty bad already.
Yes, and that's continuous flow.
Yeah. Wow. Amazing, huh?
Mm-hmm. That's on.
Whole segments are out.
Yes, gone. Now, so this is not my inability to properly image, or is it?
No.
Or is that real? Is that real? In other words,
This is real. Yeah.
This is real. Okay, because I've been having a really hard time trying to appreciate whether or not what I'm doing is good or not. And now we're on pulse flow. This is pulsatile flow now. So we went from continuous to pulsatile, but I really don't appreciate much of a difference.
No.
I found that interesting. I didn't appreciate it in this case. And remember, this is an N of 1. So we have to do this on more cases. Okay, let's go to another one. So this is go to the post pump. So this is what the patient looked like when we came off bypass. No, the bottom one, the last one. Yeah. So that was from a different video. We kept don't worry about that 22. That was not real. But this is when we're coming off bypass, 15 minutes post pump. That was the last one, was 15 minutes post pump. So this is actually, go back to the one previous. I'm sorry. You were right to start with. We had a protamine reaction on this one. So started at 8:47. So let me move this here. And let me advance to about 8:47. Okay. So here we are. This is at 8:40. In 10 seconds, we'll start weaning off bypass.
Okay.
There we go. Why is it stopping? Is it my video, or is it just the video of the camera,
It's
computer locking up?
It's still counting down if you
Okay.
look at your camera. It's going.
You can kind of see where he's coming down on the flow and filling the heart and trying to do his maneuvers. And you can watch it kind of disappearing and then speeding up again.
Kind of get the feeling that we see reappearing capillaries, huh?
I do. I sense it too. And we were seeing that as he's continuing to volume load the heart, and we're returning to more native circulation.
Yeah.
Now I'm going to jump forward just a little teeny bit, and you're up, go back. Okay, now we came off. I'm gonna go let it go, but you're gonna see it kind of go downhill. It's not gonna look quite as nice because at this point, they thought they were gonna be going back on bypass. So they had a little bit of a snafu. And then I think we did the analysis because we wanted to catch an analysis at that point. So with this patient at that point, when they decided that they were going to return to artificial circulation, we were down to 22.
Yeah.
Yep, and you can see it. There was almost nothing there. Okay, so get rid of that. And now we'll fix the patient. Do the last one. Okay, let me move this thing. And we will just turn it on and go until we get somewhere. What am I analyzing there? Okay, this is off pump, but we did an analysis, and then I did it again. Now, let me turn it back on, I think. Pretty sure we did. Hold on. I might not have. That might be it. Hold on. Let me see. I'll go back to the video though. Yeah. So that's it. So let's look at it. So now we're off pump.
Oh,
this is what we were looking at. Off pump, patient stable, looking good. Now this was a lady. She was 78 years old. She had very few comorbidities. She wasn't diabetic. She had some hypertension, something like that. Normal kidneys. Was an active 78-year-old and had a reasonably decent, body habitus and a good quality of life. And she came in and had a 4-vessel bypass done. And she actually did very, very well. She's out of the unit today. So I'll go to the analysis now and look at it. But yet, look, we're 60%.
Yeah.
Now, is that my technique? Or is it the location, or is it just that's what it is?
Well, it's
now this
that
was
big white
immediately
spot in the
post-pump.
middle does not help.
Say that again.
That big bright spot in the middle does not help.
Oh.
Show me which right here.
Yeah, you can't tell what's there.
Yeah.
Oh, because I had the gain too high. Okay.
Yeah, exactly.
Okay. Magic. We have the gain. I have the gain too high. I know he told me I had the gain too high, but I couldn't see anything, so I told him to leave it up. That's a problem right there.
Yeah,
Okay.
because it basically floods everything, and then you see that the other vessels, then flow detection becomes a bit of a problem because we need a certain amount of contrast to detect the flow.
Gotcha. Okay. Fair enough.
So that's why it's so low.
Okay, now let's close this. Now for the exciting part, and not that that wasn't exciting enough, go to our ECMO patient. Now this really interesting patient, 43-year-old police officer, was at Hospital X, had at one time an arterial PO2 of 30, got it all the way up to 42. People were high-fiving on this. Got him transferred to us, and when he got to the room, somehow I managed to get some images of what was happening with this guy. He was intubated on the vent, 100% FiO2, saturation was 72%, and he had his heart rate was about 110, and he, but other than being intubated, that was it. He wasn't, and they gave him sedation. So he was sedated as well. But he was also on Levafed, Neo, Epi, and vasopressin. All of them. So now let's take a look and see what this looked like. And I'm just going to let this run. Now, I might have to jump around a little bit because it took me a while to get an image. And again, we were just recording these off of the computer itself, not through the software. And that's why those files I sent you were so big. So here I am trying to find something.
Yeah.
Okay. And I see that happens to me a lot, Dr. Mettauer, where I find I can't get the probe to hold still. It's moving, but I don't know. I'm not moving, but it seems to be moving. And I can't.
Yeah, the tissue is moving underneath the probe.
Oh, that's what it is? Okay.
Yeah.
So here, take a look at this. How does that? Well, let me move this thing. I'm sorry. How does that look?
Yeah. Yeah, so that's okay, but you're quite close to the base of the tongue, so you need to move a bit more closer to the front teeth.
So I think I do. So let me see.
Okay.
So I'm too close to the base of the tongue. How could you tell that? What'd you say?
Because then you see these loopy structures.
The loopy structure. Okay, so these loopy structures means I'm too close to the base of the tongue. So you're saying, Magic, what are you saying? Go back to the beginning?
Yeah, he says it's better image there.
Better imaging in the beginning, okay. Let's let this play. Okay, let's let that play. So now I know what those loopy things are. I'm too close to the base of the tongue. But I'm still too close to the base of the tongue.
So there it is.
And that white stuff is just dried out saliva. So sometimes you just need to clean the bottom of the mouth.
Yeah, I learned that too. I learned that this morning. You'll see that this morning's images are a lot better. So let's see what happens. Let's just be patient and see where my probe ends up wandering to.
Yeah. Well, sometimes it's just the easiest to just let it run.
Well, keep in mind, they're also in the middle of trying to resuscitate this guy. So
yeah,
exactly. I was lucky to get an arm in there and just sort of guide it in and do the best I could do. So I didn't have the most ideal scenario. Okay, nothing to see there. So let's get out of that. So let's go to the pre, right? No, the ECMO. Yeah, pre. Go to pre. I did it again. That's why we looked at the wrong one. No, everybody, I hope you enjoyed the wrong one. Okay.
We learned what the loopy things are.
Well, yes. You know what? I'm glad we did because I learned what the loopy things mean now. That's exactly right. Okay. This one, they had gotten the patient. Still, we're not on ECMO, but they got the patient more stable, and I had a little bit better opportunity. There you go. Now, what do you see?
Yes.
We're in serious trouble. You can see how slow it is in the venules you were talking about. And this, I'm assuming, are capillaries that are just simply not getting perfused. Look, you see a little movement right there.
Yeah.
And then I think I kind of wandered around in a spitball for a minute or two. Look at that. You're missing all kinds of stuff. So hold on. I'll move it forward just a little bit. There's another. Look at that. There's nothing. I'll go.
Wow.
I think I'll go forward a little bit more here. It starts to get really good here. Okay, there you go. That's a really. That seems to me like a good image. Or are these loopy things also still the tongue?
No, this is fine. Yeah.
This is real.
You will see loops all the time because that's how they're structured. But closer to the front teeth, then they become a bit more stretched out.
Gotcha. So let's look at this analysis if we can. .75. And you had said if it's under 80, we've got a problem. But you can see
actually
there was
score should be lower.
Yeah, there was no flow.
Yeah. So,
okay.
But I think because of the movement and the bubble, I think because you can see the edge of the bubble, that kind of spoils the whole thing.
I think he's saying that it's artificially elevated.
Yes, I agree. Yeah. Okay, so let's get rid of that. Let's go to the, let's see. Well, let's look at another, let's look at another pre. Look at this one. Okay, so again, I needed to suction him out. I think I finally did. But here, look at the, it's not a great view. Let me see if I can find a better view. Okay, now, when I was asking you about the cells, is this just saliva, glop? Or is
this is saliva with blood in it.
Saliva with blood, okay.
So these are just loose red blood cells floating on top of.
So he's bleeding.
Yeah.
He was, yeah.
Yeah.
Okay, there you can see some flow there.
Yeah.
And I can maybe advance it. Nope, let me go back a little bit.
Yeah, so that analysis will be horrible because
okay, let's get rid of that. And let's go to the first one on pump, the post right there. And then we'll look at, and then this was when we initiated ECMO and had the patient stable on ECMO. I went back and again, you know, a lot of secretions that I'm dealing with. But here, this is a good view.
Yeah.
But again,
So
there
that's
I
better
go.
than before.
There I go moving around again. And I desperately try not to do that. But yes, I can appreciate a much higher velocity, though not as high as what we saw in the patient that was having heart surgery. Like you see a lot of sluggish flow right there. And I'll get back in focus here in just a second. There. So you see these vessels very small. They light up, but before, if you remember, they were just white. At least the ones that we saw. So we won't look at the analysis because of the software. So let's get out of that and let's show him what he looks like today. It was a lot easier for me today. I'm going to move this thing first. Okay, so that's what he looks like this morning.
That's a lot better already.
Significantly better.
Yeah.
Yes. Now, this is a venous ECMO. This is not veno-arterial. So his cardiac function was really essentially normal. In fact, it was hyperdynamic at the time that we were doing this because he was in this condition he was in. But he was hypoxic. And then we'll get out of that trash in a minute. There we go. I'll find another spot. Yeah, I do. You know, is that just like I said? You know, I think as I do this, I'll get a little bit better at it. It's finding there. There you go. There's a nice spot. I think that's a good image.
Yeah.
And you can see the little capillaries, or the little arterioles, the smallest, with really high flow going through them. One of the questions that was asked to me was, if you notice on some of those, let me go back. On some of them, you'll notice that it flows and then stops, and then flows and then stops. Is that a white cell that is giving it that illusion, or is the flow actually starting and stopping?
Both are possible.
Both are possible.
Yeah. Okay. So there is a thing called vasomotion, where indeed flow happens in waves. So it flows and it slows down or stops and it starts again. So that's a natural thing. And then we have white blood cells that sometimes temporarily plug a capillary and then they dislodge and then flow starts up again. So both are possible.
Very good. Can you close that screen and go ahead and open up the phone lines if you don't mind? And we lost him. I can't hear him anymore. Dr. Mettauer, he was talking and I couldn't hear him. Dr. Mettauer, are you there?
Yes.
Okay, good, yes. So we have the phone lines open for anybody that's watching. The number is 832-239-5358, and we should have a little symbol that'll pop up momentarily. There you go. There you go, okay. And you can cover us up, David, that's okay. Or just cover me, just put it up and down. And there's the number. So while we're talking, why don't you guys have any questions or anything like that? What did you think of these images? What do you think of this technology as a whole? Do you see it as having clinical value in your all's practices? What are your thoughts?
I just have one question. Is there any talk? I think it's a fascinating technology, and I think it could be an excellent tool to see what kind of perfusion we are giving our patients. So I wondered is there any talk of a development of some kind of disposable device that can be affixed to the patient's tongue or mouth so that it could be a continuous reading, and that we could really, watch, for this particular patient, our hematocrit's too low, or we're not doing what we're supposed to be doing with the ECMO, we need to make some vent adjustments, etc.
Yes.
Yes.
Wow, brilliant question. You just explained our whole 2 years of top secret development, but yes.
That's classic.
Yeah. Well, I think it's an excellent technology, but realistically, we're not going to be able to have someone on, continuous cases holding that probe in there. So I wondered if that's kind of a direction that you think is worthwhile, because I do.
Yeah.
Clearly.
No, it is, and it's definitely on the top of our list. We're working on it very hard. Mm-hmm. But as you can see, we need to find something that can fixate the probe in place under the tongue, but still doesn't fix it so much you can get it easily out.
Yeah.
So that's one of the technological difficulties that we're experiencing. And the other is that you need to miniaturize the whole thing. And that is a very significant R&D investment that is currently being done, but it will take a few years before we're there.
Yeah, I'm sure. Well, we really appreciate you letting us see this in person. It's really fascinating.
I'm waiting for John Ingram to call. He said he was going to call in. He's been asking me if we were going to open the phone lines soon. So they are open. I even texted him that the phone lines are open. He read it at 14:20, 1 minute ago. So hopefully he'll call in and there's not a problem. There he is. He's calling right now. But while they're getting him on the phone, somebody asked Joe, how can our center, you're going to love this, okay? How can our center get this device any way we could be a part of any multi-center trial? So I told him that I would ask, and then how he can obtain one. Of course, I am the only one that gets a free one, and nobody else. Okay, because I'm Joe. I got the show. Joe with the show gets the free one. But I also told him to give me a call so that him and I could possibly talk about collaborating together. I could go where he is and use the device on some of his patients, and then he can take that information and do with what he wants to do with it. So 2 things. Cool. One, hopefully I can get you a sale of the device, which will help go towards my discount later on. And then also, I guess we'll be taking some travel up to where Praveen is, and hopefully it's not in Mumbai. But if it is, we'll go there too. I don't care.
Yeah.
Fair enough. Okay.
Got a device in Mumbai, so you can go there for sure.
Good deal. Okay, Professor Ingram, you're on the phone? Hello?
Hey, how are you?
Hey, John, how are you?
Hey, John.
Hey, nice seeing you guys again. The guys look great.
Likewise. I wish you were here.
Can you hear me okay?
Yes. We wish you were here.
Yeah, me too. Good day for me because it's my day off, actually.
Good. So what did you think?
Fascinating. Great talk. And I've seen Dr. Bhatia's talk before. I have a few things, if you don't mind. I want to go back just sort of to the beginning of your lecture for the first question. I think it was the circulation coherence, part 1 there. You showed a slide. It was a little bit hard to see exactly. I want to say it was showing where you were able to correct the lactate and maybe even the base excess on the macrocirculation, but on the microcirculation, the images did not show improvement. Is that correct? Did I see that right?
Yeah. So.
Okay. So if I saw that right and understood you right, so. I know somebody already called in about the lactate, but if you are you saying that there's a little bit of a disconnect between those of us that are checking lactates and we see the lactates improve is not necessarily indicative that our microcirculation on the capillary level has improved, or is there just a lag there?
Well, there's definitely a lag, but we have not really looked at the exact correlation of lactate and microcirculation. So no one has plotted these two out. So we're not sure yet. So there is a lag, that we know for sure, but exactly how the two move together or don't move together, we don't know.
But I mean, and that's a good question. I mean, I'm surprised to hear. I'm actually surprised. Again, I've already learned something else today, which I'm not 100% convinced. Okay, just because the study said that about the pulsatile flow. But with that said, I mean, does it not stand to reason that if you have a capillary bed that is gone from 100%, we'll say, to 60%, and you have fewer capillaries, so you're going to have tissue that is not being oxygenated, it's going to be anaerobic, and you're going to have lactic acid buildup. I mean, isn't it sort of intuitive? I think the delay may be the interesting part, and how long is that delay actually going to be, and then how long, from restoration do you clear it? But I mean, I think we kind of know how fast you clear lactate.
Well, don't you think the delay probably has something to do with that acceptable time period that the microcirculation has been interrupted? He's already said that.
And whether the injury is reversible.
Right.
Yeah.
So was it too long enough to have the lactate built up, or was it in that time frame that where they could
good point.
recover?
Okay, that's a good point.
Exactly.
Yeah.
Yeah. So those are the questions.
Well, if I can interject something, there's two different ways to look at it. If you have a high lactate and then you see that you've made some changes and your microcirculation improves, then there's going to be some time that it takes for you to see the lactate improve. I guess what I was asking about is if you see, because that seemed like from your slide, you were able to correct the lactate and your blood gases, your lactate corrected, but your microcirculation did not correct. Was that something you see?
No, so that is something we aren't for sure. We do see those numbers improve, but whether they correct back to normal, so in some patients you do, in other patients you do not, and we don't know exactly why.
Mm-hmm. Well, and John, I think you bring up a very good point, and I think that this goes to my perspective on the value of this technology is that we do cases, and we manage patients in the ICU, and again, we use labs that are done intermittently that take a while to get returned to us. All the while, we've made changes while we're waiting for those labs, and then they come back, and we infer a lot of information from it, which is how we've done things for a very long time. But I think that having something that you can take a snapshot in that moment, anytime you want to see what the health of the microcirculation is going to give you some good guidance in terms of, it's really, really, really bad, and we want a blood pressure of 80, but if we, hold on, what's up? I can't hear you.
Johnny's knocking something.
Oh, John, stop knocking. They told me you're knocking your phone. But if you and I lost my train of thought. So you have.
I think you were going with the
snapshot, right?
Right. If they want a certain pressure, but maybe they're increasing the pressors, and then you look at the microcirculation.
Right.
Is that where you were going?
So the thing we're trying to do that we think is benefiting the patient is the very thing that is hurting the patient, that a blood pressure of 50 may not be that bad if you have good microcirculatory flow. And I think that it's going to be a sea change in what types of pressures we're willing to accept secondary to that. Flow is going to become much more important. I think that's always been something that I've believed, that pressure is important. You need a good perfusion pressure to drive it, but where is that threshold? And it's going to be different on every patient depending on age and a whole variety of other factors, comorbidities. But having something you can look and say, I see a very healthy, well-perfused microcirculation here, but our blood pressure is 52. Why do I want to go up on the Levafed? Why? If everything is working well, you're not developing a lactic acidosis.
Yeah. So, and that's exactly the point. And we also see that you have patients with high lactate that have microcirculatory alterations, and you see patients with high lactates that don't.
Well, that could be those hyperdynamic, high velocity no time to offload or uptake.
Exactly.
And that's a septic.
So
that would be a septic patient.
It could be, yeah. It could be a sepsis. So right now that question is still out there.
John?
Yeah, I think you hit right on what my first question was. If you have a patient whose lactates are, let's say, improved or are actually good, and you have a poor microcirculation looking on your probe, what that tells me is that there's a whole wealth of understanding that we have not tapped into. You follow what I'm saying?
Yes, and I think I know where you're going with this. And Dr. Mettauer, John, correct me if I'm wrong, because we saw this yesterday with that patient I was telling you about. We didn't see a bump in his lactate for almost 8 hours,
Wow.
but then it really climbed. So I think that the perfusion deficit, the lactate was building, but it wasn't getting into the central circulation where we could then measure it. So that was so everybody's like, well, the lactate's not going up. It's going
Exactly.
to. And it did, and it went up significantly.
Right, that's the exact thing that I was told when I had that patient immediately after, was I had him draw a lactate and it came back normal, and they're like, well, it's normal. And I'm like, no, that's just telling you where we are right now. That's why I wanted it now, because we're going to draw one later.
We need a baseline, right?
Yeah.
That was a good thought.
And it's going to be high.
Right. Yes.
Yeah.
And so I think that's very important. And I think too, washout. I mean, I think we all know that phenomenon. But at the end of the day, imaging. If you look at what's going to happen in the 21st century with medicine, it's going to be imaging. And we simply we are so, I still think, very far behind where we need to be. And we're going to be evaluating things on a much, much deeper scale with better imaging. And I think this plays right into that whole tool chest or armamentarium, if you want to use a fancy word for the same thing, tool chest of things that we have at our disposal to manage these very critically ill patients, because we're going to see more and more. That's all we see anymore is critically ill patients. We can't buy a chip shot case anymore.
Not really.
No, not unless you want to come over. Brianna, any final thoughts? You've been so quiet.
I know.
Yeah,
you guys
come on.
covered a lot.
Jump in there.
The only comment I have kind of regards the beginning of the presentation. It's more like a comment, but the slides that you presented, it showed a lot of correlation with pulsatile and non-pulsatile flow. And I just always thought of or learned that capillary shunting was always more so related to the length of CPB time, or
The what? Say that again.
The
CPB?
cardio.
the length of pump time.
The length of pump time was contributory to what?
To like capillary shunting.
Capillary shunting, okay.
Yes, and hemodilution. But the presentation that you focused on more so related to flow. So I was just wondering, do you think that's a stronger correlation? Because we never really focused on that, because certain programs are only have tools for pulsatile or non-pulsatile. So we mainly focused on what the perfusionist can do, like hemodilution and that type of aspect. So I was just wondering, like, the stronger correlation, if you had a preference or.
Well, I would keep the correlation on the number of capillaries perfused. So how many capillaries do you see, and how many of those have good flow? And that number you see steadily decrease as the perfusion is on the pump.
Goes on.
And whether it's pulsatile or non-pulsatile, that number drops regardless, but it drops more with non-pulsatile than with pulsatile. So that's basically it.
And there definitely is a relationship between length of the case, which is what you were asking.
Yes.
And so the longer the pump, the you're on the heart-lung machine, the less good it is for you.
Yeah.
Exactly.
You do realize that we're all perfusionists up here, right? This is what we do for a living. You know.
Yes.
Yeah. Not helping your cause. All right. John, did you have any further thoughts?
Yeah, I have two quick things if you have time. Can you speak a little bit to the use of neosynephrine and what you see with this
good
device?
question.
And secondly, where is the exact proper ideal location of the probe. If you pick the exact, if you have a baseline and then later you treat the patient, you come back, don't you want to be in that exact same spot? So is it exactly a sublingual in between between the teeth and the back of the tongue? Is it more close to the teeth? Would you describe that a little bit for me?
Yeah, so to start with the last one, we usually recommend 3 measurements. So one on the side, one on the other side, one in the middle. And take the average of those 3, because NS1 is usually, it could be a fluke, you could have the probe wrongly positioned, all kinds of things. So because we cannot find the exact same spot back again, you have to play a game of averages. So that's the answer of the question. The first one, did you say norepinephrine?
No, just
phenylephrine.
Phenylephrine, neosynephrine.
Neosynephrine.
Yeah,
It's just an alpha.
yeah, but not all alphas are created equal, which is of course what the pharmaceutical industry desperately wants us to believe. But on a microcirculation level, that actually is true. So we see different responses with phenylephrine and norepinephrine. But again, it looks like if you just zoom out from the literature and try to do kind of a meta-analysis, it seems like the differences in responses are highly individual. So one patient can do well on one and can do bad on another. And from a microcirculation perspective, we don't know why. And I'm pretty sure, the biochemists and have plenty to say about that. But from our perspective, we don't know. It's very hard to predict what patient will do what on what alpha.
Very good. Okay. Nestor also sent in a question, but he says that you addressed it already. His question was, he wonders how much the patient's own contractility, hemodynamic coherence, compromised or not, could contribute to the microvascular circulation or lack thereof. And of course, yeah, you already addressed that. But good question, Nestor. Of course, I just have never found a pulsatile pump that mimicked the native cardiac pump. It has a much longer systolic phase and delay phase, and then the diastolic phase is a lot less dramatic. So I don't know. I'm going to be playing with this, and we have pumps that do both, and we can convert from one to the other. And I'm going to try to get some really good data on this, because I think this is something that I want to know. And also, John, to your point, I'm going to try on each one of the cases because our first line on pump is Neo. We all have a stick of Neo that's refillable. We have in fact unlimited refills on it, and that's our main agent. So what I'll do is try to get a good image going. Have, when necessary, let's say the pressure's down around 50 or so, they'll give a bump, give a couple of hundred mics, and then I'll see what it does and see if we can visualize that on a number of patients to see if we actually do see any difference. I think that's the best way we can do it.
Yeah.
Okay. All right. Well, Dr. Mettauer, once again, you have been. I didn't mention anything about your Pranic Healing this time, but we can mention it now. No, I think it's very important. I think for anybody that's interested, look, you live a very healthy and peaceful life, and we all need it. I think it's something to be proud of. And you're actually on the various websites pretty high up on the scale of instructors. So I think that speaks well for you. But we probably all need a little bit of stress relief in our business.
It is tremendously helpful.
I can have no doubt. So we can either all learn about Pranic Healing, or we can all go to Specs and get a bottle of tequila. Either one, it works.
Either one, both will work.
Both will work. All right. Well, with that said, I think I'm going to just again thank you very, very much for your time, John. I want to thank you for calling in. I know it's late there in Amsterdam. I'm still planning on coming out to visit you. Tammy's going to come too and try to get into the secret vault and find out where that piece goes that's going to be permanently implanted and to make the job easier. And hopefully we'll have a chance to meet your family while we're out there as well, and we can go to dinner or something like that. But thank you again for everything. And
Thank you so much.
If you can send me an email based on the images you saw of what I can do to improve my technique, it would really it would mean a lot to me if you could do that.
Yeah.
And any suggestions of things you would like to see that maybe you're not having an opportunity to get anywhere else. Because John, he works in a place that has 7 to 10 ECMOs going 24/7, 365 days a year. And where we are, we have a whole variety of different cases and patients that we get involved with. So, I'm in Houston, that's a big city. So please don't hesitate to, one, give me some suggestions and on improving my technique, and two, anything you would like to maybe see so that we can at least accommodate that portion of this.
For sure.
Okay, ladies?
Thank you so much.
you.
It's a wonderful
Thank you very much for
presentation, and
having
we
me.
appreciate it.
Thanks, Dr. Mettauer. Best to you. And happy holidays.
you.
Merry Christmas, Happy New
Happy
Year.
holiday.
Bye-bye,
For
sir.
sure. Bye-bye.
Okay.
Okay,
Well, that was one hell of a show.
great.
They had a mini stroke.
Still live. We're still live.
We're still on. But don't worry. Yeah, we could treat your stroke. Don't worry. Get the micro scanner, please. No, that was a heck of a program, I think, and he's just so smart. But the technology, I think, is just, it's like anything else. I've had people say to me, "So what's the clinical value of this? What are we doing this for?" I had some people say that to me. Well, because we're learning something we didn't know. I don't really know what the clinical value is, to be frank with you. I have no idea.
Well, but it might be a great predictor of things that we're already doing.
Yes, but it's going to teach us something. That's the whole idea, is we're going to take this information and we're going to say, well, wait a minute. Why is it that when I give this, we see this microcirculation go bad? Look, it may change the way I think. Pulsatile flow, I think, is pointless. How many times have you heard me say that? That's the most ridiculous thing I've ever heard. But yet, okay, if I do enough cases with this and I see over a series of cases the microcirculation better preserved with pulsatile flow than non-pulsatile flow with our current perfusion equipment technology, I'm going to have to sort of take a step back and say pulsatile flow is definitely better. The data says it is, but
Well, that's why
I
we
wanna see it with
investigate
my own
these
eyes.
things, as hopefully that people are open to learning something new, no matter how long they've been doing this.
what say you?
I think it's a great idea. When you're coming into the field, it's easy to learn trends, and this way you can study to see what you're doing is actually beneficial. So, and then it's important to learn the usage. The more we use it, find out the clinical significance. Because right now, how would we know the significance or what amount is significant for capillary leakage or a decrease in microcirculation? So just using it will help us expand on more areas.
I got to teach you guys how to use the probe too, because I got to tell you, it's really exciting when you find that spot and you can see that the flow and you know what you're looking at. And what he talked about, I think, at the very beginning of this, which he did, I think, an exquisite job of, is the discordance that can exist between one and the other. We measure blood pressure. We measure the CVP. We measure the heart rate. We calculate DO2 with all of that, but is it getting where it needs to be?
Right.
That's, so all of that's fine unless you have an unviable microcirculation. The outcome is predetermined because you got to fix that first. That's what's got to be fixed, not just having a measurable blood pressure. And I think it's also probably very good for, helping people to have information to make, hard decisions sometimes. We've all seen it. We know what we're talking about. But now, if you have an objective measurement that you can look and see, this patient literally has, no microcirculatory flow for the past 48 hours. I think everybody knows what that means. And it's going to be, again, it's
Not just because we're able to maintain an acceptable blood pressure
Right.
with all the pressors and
Right.
other things that are
Right.
going on.
Right. Yeah. I mean, I think that's. I think that even though I'm sensitive to the pain that a family would endure, with that, the pain of watching that day after day, is I think worse. I believe. Okay. Well, I think we had a great time. Do you have any? So I know we haven't played any of our advertisements, our obligatory advertisements, and I'm probably going to get in a lot of trouble. So let's do this. I know.
Let's
so
take a 5-minute break.
No, we're not going to take a break. What we're going to do is this. I'm going to announce the program for tomorrow, which is going to be a really cool program. Okay. So the program tomorrow is going to feature. I'm going to have with me Mike Brown is going to be here. He's a seasoned perfusionist. Rebecca or Becky that you work with is coming up, and she's sort of a 5-year out type perfusionist. 12 years. Okay, 12 years. 12 years. You're 20 plus years. Yeah, you, me. Mike, you, me. I think Rodell is going to try to come. So I think, and he was a clinical instructor. You were also an instructor at THI for a period of time. You never were an instructor there? Okay, but you've been in this business long enough. You've done a lot of teaching. But the question was, how should a perfusionist deal with a difficult surgeon? And that's a conversation that we're going to have amongst ourselves and anybody from the audience that wants to call in or send questions in or anything like that.
So we're going to have a roundtable chat. Is that?
Yes, it's going to be a roundtable chat on how do you deal with a difficult surgeon. And I really wanted you to be here tomorrow because you have a lot of experience with that.
Yeah.
In your 5 short years.
Yeah, but you kind of get used to it. You know what the surgeon expects, and then you just grow thicker skin, really. You know how to treat each person according to the way they act.
That's why you're going to do well in this business.
Well,
You'll do
you.
well. That was the only real right answer. But there has to be a limit.
True.
What do you do when it's a difficult surgeon, not in the way he may treat people, being discourteous or rude or disrespectful or whatever it may be, but how do you deal with one that is maiming people?
That's not good at his job? Is that what
Yes.
you mean? Yeah, that's hard.
Yeah.
That's
That has to do with
extreme.
your ethical. So it's going to be like really hard and tough. So
It is.
It's
It
extremely
is. This is
difficult.
going to be this conversation tomorrow, if you are still there and paying attention, is going to be a tough conversation. It's going to be a really good show, and I really welcome, of course, y'all's input. Hopefully, like I did today, we had a lot of people texting and doing all kinds of stuff, and I probably missed 90% of all of the questions, but I can't do them all because I'm only one person. I need a staff. When am I going to get a staff, Magic?
One thing we said we were going to touch on, but we did not.
Tell me.
In reference to yesterday's program, we wanted to know if people had specific barriers or other reasons why they would be opposed to the AngioVac technology. And we said we were going to talk about that today. See if anybody could, if you had thoughts on that, maybe call in tomorrow
that's a
and
really
let
good
us know.
question, or call in, because we can always just go back. That's no problem for us. I can't imagine why anybody would have a problem with the procedure. Frankly, I don't see it as. I see it as just tremendously beneficial. I can't figure it out. So what we've heard through the grapevine is that one of the biggest obstacles they have is in garnering perfusion support, because they have to have us at the time for now. And I think we need to be aware of this, okay? Because you know what happens. The market will always fix itself. That's just the way this business is. But that perfusionists are their major obstacle to the advancing of the use of AngioVac as an appropriate tool. But I'll say that as far as that's concerned, and I say this about everything, every device, every technique, every tool every procedure has its place.
Sure.
So, and I think that what can happen, and I've seen it happen before, is people become a little bit skeptical in that, are you just trying to take this and like much in the same way, I won't say the name of the company, but this device company that's a cardiac assist device company was trying to say that every
ECMO.
Every patient has to have this. I think when you do that, you lose credibility. It hurts industry as a whole. And that may be part of the genesis of that resistance that people feel, is that, are we doing this just because you're selling it, as opposed to it's really the right thing for the patient? But that really comes down to education, I think. So program tomorrow is going to be a great program. You're going to love it. You want to be here. We'll see you at, I believe, what time? 1:30? Tomorrow? No, 2:45.
Yeah, 2:45.
So 2:45 until 4:30. So we're going to play all of our sponsors' advertisements now, okay? I'm going to bid you farewell, and hopefully we won't get in too much trouble. We'll play them twice tomorrow, though, okay, to make up for it. Thanks. I'll see you tomorrow.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. Livanova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. Livanova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the Livanova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The Livanova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.